If someone says, I barely salt my food, is that actually enough to know their sodium intake? Because the public conversation makes it sound like the villain is the shaker, but packaged soups, breads, sauces, deli meat, and restaurant meals feel like the real ambush. Where should a normal person start looking?
Start with the idea that sodium is necessary, not poisonous. Nerves, muscles, and fluid balance depend on it. The issue is dose and context. When intake stays high, many people retain more water in the bloodstream, which can push pressure upward. So the practical question is not zero sodium. It is how much is built into my usual pattern, and does my body handle it well?
Can you make the blood pressure mechanism less abstract? If I eat a very salty takeout dinner, what is the body doing over the next hours or days that could show up as a higher number on a cuff?
After a salty meal, the kidneys try to restore balance by excreting sodium and water. If they keep up, pressure may barely move. If the system is already stressed, or the person is salt sensitive, sodium lingers, water follows, and the heart pumps against a fuller vascular system. That extra volume is one pathway from food label to cuff reading.
That sounds like two people can eat the same ramen and get different blood pressure responses. Is salt sensitivity a real enough concept to guide behavior, or is it just a way people explain random daily fluctuations? So, if someone reduces sodium, what should they expect? Are we talking about a dramatic transformation or a modest blood pressure nudge that matters because millions of people are nudging the same risk factor?
Exactly. Sodium reduction is not a magic switch. It is a pressure management lever. People with hypertension, prehypertension, older age, kidney strain, or high processed food intake are more likely to see useful change. Someone already eating mostly minimally processed foods with normal pressure may see less. The baseline pattern decides how much room there is to improve. The fastest skill is comparing labels within the same food category. Bread against bread, salsa against salsa, frozen meal against frozen meal. The percent daily value gives a quick signal. Low numbers are easier to fit. High numbers can dominate a day quickly, especially if the serving size is unrealistically small.
Where does the advice become unsafe? I hear cut sodium so often that people could overshoot, especially if they are sweating hard, training outside, or trying to fix blood pressure without talking to anyone.
Sweat is the obvious exception. In a small 2026 firefighter study, carbohydrate electrolyte drinks improved several hydration markers compared with water after extreme heat and protective gear exercise. That does not mean everyone needs salty sports drinks at a desk. It means sodium can be useful when the problem is real fluid and electrolyte loss, not routine snacking.
If someone has high blood pressure, should they just buy low-sodium versions of everything? Or is the bigger win a pattern like Dash where fruits, vegetables, beans, whole grains, and lower sodium choices all move together?
Dash-style foods are usually a better first conversation than chasing a product. Potassium salt substitutes can reduce sodium taste-wise, but they are not automatically safe. People with kidney disease, heart failure, or medications that raise potassium need clinician guidance, because excess potassium can be dangerous even when the package looks heart-friendly.
What is the fairest way to judge whether sodium changes are working? I worry people will expect to feel different after one low-salt lunch, when the real signal might be a home blood pressure average over weeks.
That is why the useful intervention is often boring and timely. A shopping note, a save lower sodium brand, or a prompt before ordering. A 2026 review of just-in-time digital diet interventions found more consistent improvements in near-term behaviors, including sodium restriction behaviors, than in long-term clinical outcomes. Translation: prompt can help choices, but they do not replace follow-up. Kidney disease is where generic sodium advice becomes too blunt. Dialysis patients, for example, may have individualized fluid, sodium, potassium, and phosphate limits. A 2026 review found nutrition education improved knowledge and quality of life in dialysis populations, but several lab outcomes were inconsistent. That argues for tailored dietitian-led plans, not internet targets.
So the clinician line is not only I have a diagnosis, it is also medication changes, dizziness, swelling, heart failure, kidney disease, or blood pressure that is still high despite effort, right? Sodium is food, but the system it touches is medical.
That is the clean summary. Sodium is essential. Excess is common. Blood pressure is the main outcome to watch. Start with the sodium hides, packaged foods, sauces, breads, processed meats, and restaurant meals. Compare labels. Repeat the swaps you can live with, and judge the result by blood pressure trends. If kidneys, heart failure, medications, or heavy sweat are involved, personalize the target.